Welcome everybody to this podcast specifically dedicated on how to use the correct microcatheter in complex intervention and CTOs. My name is Pierfrancesco Agostoni. I'm an interventional cardiologist and specifically focused on CTO. I work in Antwerp, Belgium, and I have the pleasure to have here with me today and to introduce you Professor Carlo Di Mario, which is a well-known interventional cardiologist, currently the director of the cardiology department in Careggi University Hospital in Florence, in Italy, and currently also president of the EuroCTO Club. So welcome, Carlo. Just let me start with the first question to you about microcatheters. You mentioned in previous podcasts, like the one you did with Roberto Garbo some days ago, that microcatheters are very important in all complex lesions. But why do you claim that for CTO they are even indispensable?
Thank you for your question, Pierfrancesco. I think it's not only me to find indispensable the use of microcatheters for recanalization of chronic total occlusion. You are certainly familiar with the global expert consensus document, more than 100 different authors that Dr. Brilakis managed to put together to write what are the most important principles to follow for a successful recanalization. And you see, among the main commandments to be followed, number 3 is use of a microcatheter for guide wire support. Same thing if you look at the most recent consensus document from the EuroCTO Club, the 2019, that starts saying about microcatheters in the current era of CTO PCI, guide wire should always be used with an over-the-wire device, microcatheter, and I would say over-the-wire balloon belongs more to the past. Why? I think advancing a microcatheter at a variable distance from the tip of the guide wire fine-tunes the strength of the tip of the guide wire, avoid prolapse along the guiding catheter and in the proximal segment of the artery, and you avoid to lose strength due to tortuosity. It also improves the torqueability and the tactile feeling that you get from your wire when it touches and enters the occlusion. Another practical issue, the first wire sometimes is used to just get to the occlusion point, especially if it's not ostial or very proximal, and then will be a workhorse wire. You can't start with a Confianza if this is the wire that you need to engage a very stiff proximal cup, and exchanging through a microcatheter is of course advisable to avoid damage to the proximal part of the vessel, especially if there is disease. But also within the occlusion, you may have a reason to exchange. You try with a relatively soft wire, say a Gaia second, it doesn't go. You want to go to a third, you want to go to a Confianza 12. At that point, it will be much easier if you do it with your microcatheter in front of the occlusion. But once you have also done your puncture of the proximal cup, you may advance the microcatheter, just gaining enough ground within the occlusion to then de-escalate, not only increase, step up the strength of your wire, but also step down to a safer wire to go into the body of the occlusion and reach the distal end of the occlusion. All this is allowed by an appropriate use of a microcatheter, in my view, an indispensable step of the CTO procedure.
Yeah, it's a very convincing presentation, Carlo. Thank you very much. Nowadays, we have a huge amount of microcatheters on the market available. So for the, let's say, for the young operator that has to start a CTO program, how can they orientate in this jungle, and how to select the right microcatheter for the different tasks that we have to deal with during CTO intervention?
Well, Pier Francesco, you are right. Certainly there are many, but I think in a way this is also due to commercial reasons, and you can easily put together a few different types of microcatheter that are useful for one or the other tasks that are needed for CTO recanalization. So the differences are they can be thinner or thicker, they can be tapered or untapered. Torqueability is also an issue. Some you can just push, some they are made of multiple braided wires and have the ability to be truly torqued within the occlusion or to cross a collateral. They can be with a straight tip or can be angled. They can have a single lumen, they can be dual lumen catheter, and some have also an ability to screw them with a spiral that gives more support when you are within the occlusion. So how to choose the correct microcatheter? It depends what you need. In general, for anterograde attempt, if you have a large enough guiding catheter, I tend to prefer a microcatheter that gives me a bit more support, so relatively large, with the ability to reach the proximal end of the lesion and to engage also the occlusion. In general, is not absolutely needed to have a torqueable microcatheter, and my standard, you will see from some example that I will show later, is a standard microcatheter which allows you to do all what I mentioned in the previous discussion. A final point I like mentioning is about dual lumen microcatheters, because this is somehow the real novelty in the field of CTO recanalization. For this reason, the most recent document of the EuroCTO Club spent a few pages to describe the many solutions that they offer, because with dual lumen you can use the microcatheter to engage a side branch when you have an occlusion stumpless starting at the site of the side branch, and use then the second lumen to engage a stiffer wire, having the support of the microcatheter to go inside the occlusion. You may use it to, once you have crossed the occlusion, to engage a side branch that starts at the distal end of the occlusion, like often happens. The reconstitution of the vessel distal is often at the side of the side branch. You can use it for parallel wire technique, and this is, I think, particularly helpful way of revive a technique that otherwise was somewhat going to disappear once it was complicated with two separate microcatheters, difficult to stick inside the same guiding catheter, with complexity moving and so forth. Using a dual lumen microcatheter, I think, made again this technique viable for the not rare chances that the first guide wire tends to be subintimal, immediately distal to the distal end of the occlusion, and then you can start advancing a dual lumen microcatheter and using a second guide wire.
Thank you very much, Carlo, for this beautiful overview. I think it's also important to mention for the young physician that want to start a CTO program, it's indeed important to choose, let's say, one type of microcatheter according to all the different characteristics of the microcatheters that you mentioned, and not have all of them on the plank. Otherwise, you will get confused. Just choose one and stick to that and try it. And then if you're not happy, maybe change to another one. But one for each type is much more than enough to start a CTO program. So Carlo, after all this theoretical background, we are really curious to see if you have any example to show us how to use microcatheters in CTO. It would be great if we can have an example from you with maybe a simple CTO and how you use your workhorse microcatheter in that setting.
Thank you, Pier Francesco. That's exactly what I decided to select. Of course, you will use thin tapered microcatheters for epicardial collaterals. You may use intermediate tapered microcatheter for septals, but the bulk of the work is anterograde recanalization, and that's what most operators tend to do. And let me share with you a case of a relatively young gentleman, 56 years old, with the usual risk factors, no inferior Q waves, but, as often happens, some evidence of subendocardial leg gadolinium enhancement in the inferior wall, but less than 50% in thickness, and with proven viability with dobutamine stress. Ecco, not much symptomatic. The patient had more dyspnea than angina, but you know that sometimes this is the prevalent symptoms in CTO patients. So the basal angiogram, if you look in the wrong view, looks a subocclusive lesion, but looking at the RAO view, it's obvious that you were following some collaterals is a true occlusion, and you have seen a bit an unusual lateral view that sometimes I like for the mid segment of the right coronary artery. There are collaterals, so there are chances, in case the anterograde approach doesn't work, to follow these epicardial microcatheters from the left circumflex, but let's try not to spoil our possibility to go through a relatively short proximal occlusion without visible calcium anterogradally. And to do that, you need a good wire and you need a microcatheter. And I confessed, I believed that a lubricious wire like an XTR was likely, with some support, to go through this occlusion. Again, it's not long, it's not calcified, it's a young gentleman. In fact, it didn't, and proved then helpful to have a microcatheter that could go exactly at the site of the occlusion and then restart with the Gaia type with the lowest strength, which is the first, with appropriate support. This wire could be steered through this occluded segment, reach the distal end at occlusion, and at this point, once I had my wire in the third segment of the right coronary artery, I could advance the microcatheter. When I say is not a torqueable microcatheter, in fact, I tend to push and torque together. I think all microcatheter has the ability to have somehow an easier progression when you do that. This went extremely smooth. And at this point, what I did was, also it was obvious that I was at the distal end of the occlusion, but to inject to see very well the distal branches. And at this point, since I liked to have a relatively supportive wire, as I've chosen a Sion Blue ES, to go into a large branch rather than a super small distal artery. At that point, I could retrieve the microcatheter. We have shown last time how to do it. You simply advance a balloon, blow it up near the tip once you have withdrawn your microcatheter, and by keeping the wire in place this way, you will then re-advance a normal monorail, like in this case for pre-dilatation, stent implantation, post-dilatation with a 3.5 millimeter balloon up to 20 atmospheres to achieve the final result that you see here in two views. Such a simple occlusion anterograded, no CK rise, no discomfort during the procedure, and an excellent, in my view, durable long-term result, greatly facilitated by the use of a microcatheter. We always think of special microcatheter, dedicated microcatheter for occlusion, but believe me, this was an Avician microcatheter. I use it as almost as a routine for these simple cases. They work extremely well.
Great case, Carlo. Beautiful result, and you made something looking not so easy, very, very easy, and that's fantastic to see. I would like to thank you, Carlo, for this amazing presentation. And I think we had a very, very educational session about microcatheters in CTOs. And let me thank also iVascular for the support and the sponsorship of this podcast. Thank you very much.
Thank you, Pier Francesco. It was my pleasure.